related to neurosurgery or may need neurosurgical intervention. Also, I'm going to talk about the main subject of this lecture is brain abscess with its details, which I'm going to give you the full details about it, which every doctor should know. I told you many times that you are not going to be a neurosurgeon, you are going to be a general practitioner, and I'm going to give you the ABC, which every doctor should know about this subject. And lastly, to finish the lecture with one of the neurosurgical emergencies, which is a case of infection called subdural empyema, which the patient at which will be toxic and they need surgical intervention as urgent as possible. Okay, now, first of all, as I told you, these are the subjects: bacterial meningitis and the other complications, brain abscess, subdural empyema. Regarding bacterial meningitis, seldom requires neurosurgical interventions. And usually you know that they are treated in the medical department, whether general medicine or in neurology medicine, and by giving them the appropriate antibiotic for the high doses. And I'm not going to enter in these details. Now, how the bacterial meningitis will progress? They will be passing into the following stages. First of all, maybe just meningeal inflammation, or maybe subpial encephalopathy, cortical venous thrombosis as complications, cerebral edema, which may require the measures which I mentioned to you in the second lecture, treating cerebral edema and significant temperature, and may sometimes lead to death of the patient. How we are going to diagnose cases of bacterial meningitis? You know that bacterial meningitis is diagnosed by obtaining CSF sample via lumbar puncture, and sometimes we may be in need for a CT scan of the brain or MRI to exclude the complication of meningitis. I told you when I spoke about hydrocephalus that one of the complications of meningitis was hydrocephalus. And I told you at that time that the type of hydrocephalus as a complication of meningitis is communicating hydrocephalus, and CT scan will be mandatory to diagnose this complication of meningitis and how to may need interference with the patients to the patient. Now, a treatment of bacterial meningitis, as you know, in the medical department by broad-spectrum antibiotics with the doses of them very well known by the medical department. Now, what are the complications of meningitis, which sometimes may require neurosurgical intervention? First of all, cerebral edema. Cerebral edema may be a complication of meningitis, which may require treatment at the surgical department, neurosurgical department. First of all, by giving them the measures like mannitol or other things. And you know that sometimes we may be in need for decompressive craniotomy to relieve the pressure from the brain. Seizures sometimes as a complication of meningitis. Hydrocephalus, as I told you, is a communicating type of hydrocephalus, not obstructive, at which there will be dilatation of all ventricles, as I mentioned to you. Lateral ventricles will be dilated, third ventricle will be dilated, and the fourth ventricle will be dilated. And to diagnose, in fact, the story will be just like this. The patient present with high fever, headache, neck stiffness, and all frank features of meningitis. Then after that, the patient will be admitted to the medical department. They took CSF sample from via lumbar puncture and discovered to be having bacterial meningitis. And they start to give him the appropriate antibiotics. After a while, the patient started to improve day after day, but suddenly the patient got deterioration, and lastly, he may got deterioration level of consciousness, may also have loss of consciousness. They examined the patient, and they saw that this patient was having bilateral papilledema. And they sent the patient for CT scan of the brain, discovered to have hydrocephalus. So they will consult us as in a surgical department. Please, this patient have hydrocephalus as complication of meningitis. How to deal with this patient? You know that we are going to take CSF sample by lumbar puncture, which is not contraindicated, as I mentioned to you. We have two cases at which there's increased cranial pressure and there's also papilledema, but we can't do lumbar puncture. One of them is communicating hydrocephalus. The other, as I told you, is benign intracranial hypertension or CD tumor survey. So that we are going to take sample of CSF. We are going to see the quality of CSF, the clearance of CSF, whether it's crystal clear or affected, and we send the sample. Also, by this lumbar puncture, we are going to deal the patient as therapeutic lumbar puncture, as much as you aspirate CSF from the, or take CSF for the lumbar puncture, the patient consciousness will be improved and sometimes may recover completely by this temporary measure. After that, if the CSF was crystal clear, then we can do shunting for this patient, or if it's not clear, by microscopic examination, we will do external ventricular drain and to continue with antibiotic. Subdural infusion or subdural empyema, which is the last topic in this lecture, inshallah, also may be a complication of bacterial meningitis. Brain abscess, which is the most important and prominent subject of this lecture, also may be a complication of meningitis. And lastly, ventriculitis may be a complication of meningitis. Now, you can see this picture showing to you bacterial meningitis with cerebral edema, edematous brain, dusky brain, as you can see the color of it is causing this post-mortem specimen. Also, this bacterial meningitis with cerebral edema as well. You can see the hypodensity surrounding the brain. Bacterial meningitis with cerebral edema as appear on MRI of the brain, and cerebral edema as well. Bacterial meningitis with suppuration, you can see the pulse on the surface of this brain in this post-mortem specimen as well. Now we're going to talk to you about as I told you, the most important subject of this lecture, which is the brain abscess. Before I was coming to start to speak about brain abscess, a brain abscess, in fact, it is a space-occupying lesion to start with, so that we are going to deal with something just like brain tumors. Put in your mind the following important points before I'm going to start. You must be, as doctor, having high degree of suspicion that this patient may be having a space-occupying lesion, as I told you in the last lecture when I told you about the details of brain tumors. That the patient may be having, for example, headache, morning headache, nausea, vomiting, etc., which are mentioned of increased cranial pressure, and sometimes may be blurring of vision and focus deficit. Now, as we are going to deal with patients with brain abscess, now the same things which I mentioned to you in the last lecture of brain tumors also will be applied in this patient of brain abscess. Also, a space-occupying lesion may lead that the patient got a headache, morning headache, nausea, vomiting sometimes, blurring of vision, examination may receive papilledema, and sometimes also focus deficit. But the difference at here, that everybody of us think or suspect that any patient having abscess in the body, he will be toxic, have high fever, and the general constitutional symptoms will be very frank. All these general constitutional symptoms can be applied, for example, breast abscess, perineal abscess, or abscess in other way in the body, except in case of brain abscess. And you next, inshallah, in the next minutes, you will know why these general constitutional symptoms are not apparent in case of brain abscess. And you are going to see that 50% of the patient having brain abscess will have no constitutional symptoms like fever, and the patient will be toxic. Even the other 50% who are having these general constitutional symptoms will be having very mild constitutional symptoms. For example, fever may not be as high as in other abscess. Maximum will be, for example, 38 degrees temperature. To start with, regarding etiology and source infection in case of brain abscess. A brain abscess, bacteria will go inside the brain. What are the sources of or source of this bacteria to enter inside the brain? First of all, hematogenous separate. Second, direct separate from nearby area, or post-traumatic. Now, in hematogenous separate, from a non-septic site or occult focus, examples from dental infection, respiratory tract infection, or endocarditis, usually cause multiple brain abscess. You know that this blood will cause showering of these bacteria to be scattered all over the brain through the vessels of the brain, so that you suspect that this patient will not have single brain abscess, maybe multiple brain abscess scattered all over the brain. This route is commoner in patients having congenital heart disease with right to left shunt, and you know why? Because the right heart have the deoxygenated blood, or the blood having the, for example, the bacteria, and going to the left side and shower to the brain. Direct separated from adjacent affected paranasal sinus or middle ear or mastoid infection, so that put in your mind that paranasal sinus infection, middle ear infection, or mastoid infection is quite important because of their complication may be brain abscess, so that they should be treated promptly and exactly as the wanted antibiotic to be given. Post-traumatic direct inclination from trauma, for example, after head injury or after surgery, for example, after craniotomy, sometimes may got post-traumatic or post-craniotomy brain abscess. But in spite of all these, in 25% of patients, no cause can be identified, which is not a small number. I mean, 1/4 of the patient will have no identified primary source of infection. I mean, they will not have right to left shunt, they don't have mastoiditis or medial infection or that's media or parental sinusitis, and they don't have a history of trauma or direct surgery. These are how the source of infection. For example, this is a blood spray that's from mastoid infection, from parental sinus infection. And this diagram showed you that by multiple emergency separate multiple brain abscess. This is from separative otitis media to go. And in fact, in case of direct separate, the abscess will be nearby the source of primary infection. For example, from separative otitis media, it will attack the temporal lobe of the brain. Not to suspect that this separative otitis media was in the frontal lobe, for example, brain abscess. And in fact, in case of direct separate or post-traumatic, the abscess will be single, solitary brain abscess, not like hematological separate, which I mentioned to you, it will be multiple brain abscess. Post-traumatic also abscess, for example, after head injury. We have what's called high-risk patients for brain abscess formation other than normal people. And these include like cyanotic congenital heart disease with right to left shunt, as I mentioned to you. Immunocompromised patients, like patients with AIDS or other diseases, also will have high risk to get brain abscess. Diabetic patients, they have low immunity as well. Solid organ transplant. Why? Because, for example, after kidney transplantation, in order that the body not to reject the new organ, they are going to give the patient immunosuppressant drugs that the body immunity will not be attacking the new organ. So this low immunity, which we induced for this patient, will result that this patient is liable to get brain abscess more than other people's. Hematological malignancy also may be a risk factor for this patient, and you know that this will attack the result in low cell, for example, YPC or abnormal cells. Long-term steroids also result in decreased immunity and may result also in brain abscess. And remember, please, this last point, that steroids may be a factor to let the patient be low immunity or liable for brain abscess more than other normal people. After that, what about brain abscess pathology? In fact, this is quite important because brain abscess will pass into 4 stages: the early cerebritis, late cerebritis, early capsule, and late capsule formation. As any other abscess in the body, you suspect that the abscess will be just like a sac, a cyst containing pus. But in case of brain abscess, this brain abscess will start first of all with cerebritis. For example, in other tissues, we can call it as cellulitis. But here, cerebritis, early cerebritis and late cerebritis, early capsule and late capsule. In late capsule, the abscess will be completed and mature capsule containing the pus. Now, early cerebritis in the early 1 to 3 days with inflammatory cells only. From 4 to 9 days, there will be late cerebritis with formation of necrotic core. This necrotic core will be the site of cyst in the future, an increasing number of macrophages and fibroblasts. Early capsule formation from day 10 to 13, and that capsule formation, the mature capsule, will be formed by day 14 and over. 14, 15, etc. Now, also regarding pathology, that the formation of collagen capsule in a developing abscess is the single most important responsible that limits the spread of infection to the rest of the brain. And this is quite protective for the brain. You know that the brain is quite important organ to the body, and the gut preserve this brain from being infected by many abscesses by the formation of collagen capsule. And as I told you, the general constitutional symptoms will be limited here in the brain. One of the causes that the collagen capsule will prevent the spread of abscess to the body or to the other sides of the brain. So that the collagen capsule is very important responsible that limits separate of friction to the rest of the brain. You know, you can see this post-mortem specimen showing to you the collagen capsule, which is very clear in this coronal section of the brain, and this is the cavity of the brain abscess. Other collagen capsule formation also, this is the cavity of the abscess. Now, what about the clinical features of brain abscess? And this is, as I told you when I spoke about the brain tumors, I told you that the clinical features are the most important part of the lecture, because you are responsible for this, and you are going to be faced with patients having some of these features, and you must have high degree of suspicion that this patient may be having specific malignancy like tumor or like brain abscess. Now, features of resistant cranial pressure. And you know this, I will not repeat them again. There may be headache, nausea, vomiting, etc., which I mentioned to you in the second lecture. Seizures sometimes, especially if the temporal lobe is involved. Meningeal irritation as well, like stiffness and etc. And phonological deficit, phonological signs. These are just, I mentioned to you in the last lecture of brain abscess, brain tumor, sorry, when we talked about what are the signs, symptoms, and signs of frontal lobe lesion, parietal lobe lesion, temporal lobe lesion, occipital lobe lesions, cerebellar lobe lesions, cerebellar or the brainstem lesions. Now, systemic feature of infection like fever is present in half of the patients and usually of low grade, as I mentioned to you. That 50% of the patients will have no constitutional symptoms, which we suspect that any patient having abscess will be toxic and high fever here. No, they are fever not present in half of the patient, and this half will have very low grade fever. Now, before I'm going to talk about investigations, I want just to mention to you important point that in the examination, I mean the we may give you a question, the following question: what are the clinical features of patients having right frontal brain abscess? Okay, you know that in the last lecture I told you we can give you many questions regarding brain tumors. But for example, what are the clinical features of patients having right frontal brain abscess? Right frontal brain tumor, left frontal brain tumor, right parietal brain tumor, left parietal brain tumor, or occipital, temporal, cerebellar, etc. Here we can give you a question: what are the clinical features of patients having right frontal brain abscess or left parietal brain abscess, or etc. So I put in your mind that you must mention to me the features of resistant cranial pressure, seizure in case of temporal lobe, meningeal irritation, focal signs, according to the loop which I mentioned to you. And you must finish by saying that systemic feature of infection, like fever, is present in half of the cases and usually of low-grade fever. What are the important investigations to be done for patients having brain abscess? Investigations include laboratory investigations and radiological investigations. Radiological investigations, which are I mentioned to you in the first lecture, including, for example, the X-ray, CT, and MRI. But here we are going to add laboratory investigations. What are the important laboratory investigations? For example, white blood cell count and ESR, erythrocyte sedimentation rate, are usually elevated. Measurement of C-reactive protein is useful in differentiating brain abscess from tumor, as is effective in case of abscess, but not in case of a tumor. And next, we are going to talk to you about the differential diagnosis of brain abscess, whether single or multiple. One of them is tumors. And to differentiate them, you can do C-reactive protein, which is helpful in differentiating brain abscess from tumors. As I mentioned to you, that in brain abscess to be elevated. Lumbar puncture, as you know, is contraindicated in case of brain abscess to avoid fatal brain herniation. And now, anyone will ask me, is lumbar puncture is of benefit in case of brain abscess? As I told you, that there is what's called collagen capsule. It will prevent the separate of pus to the other parts of the brain. And we suspect that even a lumbar puncture, if it is done, will not give us good information. Radiological investigations include CT and MRI are the investigation of choice. CT brain performed with and without contrast. We must give the patient contrast, and MRI is done also with gadolinium enhancement, I mean gadolinium contrast. The contrast in CT brain, you know that it is iodinated contrast, while MRI gadolinium contrast. They will show, I mean CT or MRI, single or multiple spacic malignancy that's well delineated with an enhancing wall with variable surrounding edema. Now, the typical picture seen in CT MRI is ring enhancing region. Ring enhancing region. This ring enhancement will be appearing as either rounded or oval in shape. For example, this is a brain abscess. If you see this kind of patient having brain abscess, this is the abscess, and this surrounding perifocal edema. This is left parietal brain abscess surrounded by perifocal edema, as you see in these two images, but these are without contrast. Now, after contrast, what will happen? Very clear ring enhancing lesion. You can see it very well. So this is a case of brain abscess. Now, returning back to this, this is the without contrast, and this is after contrast. It is very clear to you. Also, this is a case of ring enhancing lesion, MRI of the brain, and showing this also left parietal brain abscess. The differential diagnosis of a single brain abscess in CT or MRI is either solitary metastasis, number one, a primary brain tumor, or cerebral infarction. All these can be mimicking or maybe similar in CT MRI to brain abscess. So we must put them in the diagnosis of brain abscess. While differential diagnosis of multiple brain abscess include multiple metastases and tuberculoma, TB of the brain. Now then, what about the treatment of brain abscess? A treatment of brain abscess, as any other infection in the body, we are going to put in our mind that this patient may be in need for medical treatment. And in fact, some cases of brain abscess are treated by medical treatment only, including the antibiotic, as you are going to see later on. Surgical treatment is other choice for treating brain abscess. And put in your mind that not all patients with brain abscess will be treated by surgery. Maybe treated by medical treatment, and sometimes maybe in need for surgery. Non-surgical treatment, medical treatment, this is indicated for abscess that is less than 2.5 centimeters in diameter. Small abscess. And it includes the following. First of all, antibiotic. Appropriate antibiotic selection is based on culture and sensitivity result. And you know, if I'm going to take a sample for culture and sensitivity, this means I'm going to drain the abscess. So that we are choosing like penicillin-G, trimethoprim, sulphamethoxazole, and aminoglycosides. Corticosteroids help to reduce cerebral edema. But put in your mind, yes, the corticosteroid can help reduce the cerebral edema, but in fact, they are going to delay the capsule formation. So that there's controversy about use of corticosteroid in brain abscess. Some said yes, give them antisteroid. Others said no. You know that the collagen capsule is protective to the brain from the pus. And we must have this collagen capsule as rapid as possible, not to be delayed. So that as far as corticosteroid will delay capsule formation, sometimes not used. But if the patient is, for example, having severe edema, severe surrounding perifocal edema, and deterioration of consciousness, at that time, we may give them corticosteroid. Now, anticonvulsant therapy can be as prophylactic, could be given to patients mainly if the abscess in the temporal loop to avoid this complication. Regarding surgical treatment of brain abscess, now in 2.5 centimeters, as I mentioned to you, if it's less than 2.5 centimeters, we can treat them with medical treatment, antibiotic. Now, surgical treatment of brain abscess, in fact, have two lines of treatment. Either will be aspiration of the brain abscess or excision of the brain abscess. Aspiration means that I am going to do a small incision over the maximum diameter of the abscess and doing burr only in the skull, and then opening a slit like in the dura, and introducing what's called the brain cannula inside the brain to reach the abscess cavity and drain the abscess. This is called aspiration. While in case of excision of the brain abscess, at that time, I'm going to do a craniotomy, formal craniotomy. For example, right frontal brain abscess, I'm going to do right frontal craniotomy. I'm going to open the skin as a flap and bone flap and dural flap, and gyrotomy I make in the brain, and then to enter inside to reach the abscess wall, and to do excision of the abscess wall, the abscess with its wall. Maybe a single piece, or maybe we do aspiration and then remove the wall of the brain, of the abscess. Now, what are the indications for aspiration? Through a ball hole, and sometimes maybe we can use a stereotactic surgery, which I mentioned to you in the last lecture, for perfect localization of a small size abscess. These are indicated for the following cases: multiple abscesses. Multiple abscesses. You know that I'm not going to do multiple craniotomies for different directions to remove the multiple abscess. So that just only aspiration. Deep-seated abscess, because this deep-seated abscess, and I'm going to do craniotomy, and gyrotomy will be devastating to the patient, and he will get focal deficit, which is permanent the whole life. So that's safer to do for him aspiration. A critical location like motor or speech area, also we try to avoid these areas for craniotomy. And poor general condition of the patient, like for example old age, diabetic, we don't want to do a big incision for this patient. And as I told you, the aspiration done by using a blunt tip needle, which is called brain cannula, through the ball hole. Now, aspiration or drainage is followed by intravenous antibiotics for at least 6 weeks. At least 6 weeks, because you know that aspiration of the abscess, definitely I will not be able to aspirate the whole pus from the cavity. Definitely. The aim of aspiration, first of all, is to do decompression of the size of the abscess. Number one. Number two, in decompression, I'm going to remove as much as I can from the pus. Then I'm going to take a sample of pus to send for culture sensitivity, and this will direct me towards the appropriate antibiotic needed for this patient. So that we know that after aspiration, I did not remove the whole pus. There is still, for example, few cc of pus, and in order to stop the enlargement of this abscess, I'm going to give you the patient antibiotic for at least 6 weeks. First of all, I'm going to start in the first few days by empirical antibiotics, and then after the result of culture sensitivity, I'm going to give the patient 6 weeks of appropriate antibiotic according to the culture sensitivity of the patient. This is how we do stereotaxy, and we are going to introduce this through the ball hole, and this will direct me directly to the site of the brain abscess, even if it is a small size brain abscess. Other aspiration of the stereotaxic surgery, this is called the helmet, and it is put to the head of the patient and fixed by under local anesthesia to the head. Then this patient will be entered inside the CT scan of the brain. We are going to take CT scan of the brain with this helmet applied to the patient. Then we are going to take the patient from CT scan to the theater. The helmet is still here in place. Then I'm going to sterilize the brain and sterilize the helmet. Then this will direct me from CT scan. They will give me the X and Y and Z access to the brain abscess. Then I'm going to introduce the brain cannula inside through this small bar hole. It will reach me to the side of the abscess, even as a small size abscess, like even 1 centimeter in diameter. Also has the picture of stereotaxic surgery. You know that this will reach me directly for this deep-seated brain abscess. These are multiple brain abscesses. You can see this number 1, this number 2, and after contrast, you can see that there are 3, not 2. This 1, 2, and this is the third one. There's are turn back. They appear just as 1, 2. This is a smaller one, not so apart. But after contrast, ring enhancing region, ring enhancement of this multiple brain abscess. Other deep-seated abscess, 1 or 2, 3. Now, aspiration, as I told you, is followed by intravenous antibiotics for at least 6 weeks, according to the culture and sensitivity from the pus. Then, the other method of treating brain abscess, as I mentioned to you, we have medical. If it is less than 2.5 centimeter, more than 2.5 centimeter, like 3 centimeter, will be treated by surgery. As I mentioned to you, either 2 surgeries, either aspiration, which I told you just for a few seconds, and the second route is surgical treatment by excision of the abscess via craniotomy. Here, the indications for craniotomy to remove brain abscess, multilocular abscess. We mentioned that multiple abscess by aspiration. Why multilocular? I mean single single cavity containing multiloculi of brain abscess. Superficial abscess, which is accessible, and I'm not going to harm the patient brain, opposite to the deep-seated abscess. The presence of foreign body, and why the presence of foreign body is indication for excision, because this foreign body is the cause of a brain abscess. And if I just remove the abscess, for example, by aspiration, the source of infection will still, the foreign body. So that at that case, we must do craniotomy, removal of the abscess, and removal of the foreign body, which is the causative factor for this abscess. Fungal abscess, because they respond poorly to aspiration. Cerebellar abscess also, because this may result in hydrocephalus. Abscess containing air, because this will not resolve clearly or with a short time. Abscess with CSF leak. Here we are going to find the source of leak and suture it. Abscess with which failed to resolve after, for example, aspiration or after antibiotics, we are obliged to do for them the excision of the abscess. This is multilocular abscess, as you can see. This is the abscess cavity, and this is the septa separated between two loci of the abscess. It's superficial abscess. This one is indication for excision, multilocular. This is indication. Why multilocular? Because if I am going to aspirate abscess, it will be aspirated from one locus only. The other cavity will be containing the pus and not be aspirated, so that I'm going to excision of the whole cavity of the abscess. Here, this is, as you can see, superficial abscess. It is accessible, and I can remove it through craniotomy, and you see that there is no brain tissue over it, and I can remove it safely and protect the brain. Foreign body also with as you can see, this is the abscess and this is the foreign body. The aspiration of the abscess will result in recollection of pus, because this is the source of infection. So that we must do a craniotomy, excision of the abscess, and removal of the foreign body in order to avoid recurrence of brain abscess. Cerebral abscess, as you can see, that this is starting to do compression of the fourth ventricle and may result in hydrocephalus. So it's an indication for also excision of the abscess. You know that the posterior fossa is small fossa, and any structure at here, even if we have, for example, extradural hematoma, small in size is indication for surgery in the posterior fossa, not like small size extradural hematoma, for example, in the frontal area. Also, the cerebral abscess causing complete obstruction of the fourth ventricle, and you definitely getting hydrocephalus. And if there is hydrocephalus, as I told you in the last lecture, the lecture of hydrocephalus, priority for hydrocephalus, and then we are going to deal with this abscess. All these abscesses are indications for excision of the abscess, not for aspiration. The last topic of this lecture, inshallah, I'm going to talk to you about one important subject, which is sometimes a complication of bacterial meningitis, as I told you, which is subdural empyema. Subdural empyema, you can imagine that this pus is present in the subdural space. And in the subdural space, this pus will cause irritation of the brain, and the patient will be agitated. And in fact, this is an indication for urgent surgery for these patients. Subdural empyema, what about the source of infection for this? Although uncommon, may develop following sinusitis or mastoiditis. It carries a high mortality of 5 to 10%. So that I will concentrate again about treating patients having sinusitis or mastoiditis promptly with a proper antibiotic and test media as well, because their complication may be brain abscess or maybe subdural empyema, which is quite dangerous to the patient and may result in high mortality of 5 to 10% of patients. Blood is collected in subdural empyema over cerebral convexity or in the parafalcine spaces. The clinical features of a patient having subdural empyema. Here, opposite to the patient having brain abscess, the patient will be toxic. Headache, severe headache for the patient. Fever and meningism are very frank in these patients. Seizures are common, and even sometimes we may have refractory seizure not respond to proper anti-epileptics. Phonogenetic deficit, which may progress rapidly to altered mental states and even to coma and death. Now, Put in your mind the following, that the combination of fever and seizures with a background of sinusitis usually diagnostic of this lesion, I mean of subdural empyema. What are the investigations needed for a patient having subdural empyema or suspected to having subdural empyema? CT scan and MRI are mandatory. Despite subdural empyema is a neurosurgical emergency, diagnosis is often delayed as the collection on CT usually so slight and frequently missed, while in MRI is more useful than a CT scan. The diagnosis is when it's doubtful, it's be much more clear in MRI than in CT scan of the brain. And we suspect, I told you about cases of subdural hematoma and head injury, that there will be a crescent-shaped lesion surrounding the brain in subdural space. And in case of subdural empyema, don't suspect to see that the crescent is very thick. No, it will be very, very small and maybe missed even in CT scan of the brain. You can see this is the case of subdural empyema, bilateral. What about the treatment of patients having subdural empyema? Now, here, once you diagnose these cases, the treatment will be by craniotomy and thorough drainage of the pus, followed by intravenous antibiotics and anticonvulsant use mandatory, because this patient may got refractory epilepsy. So that here there is nothing called conservative treatment or medical treatment. Once you diagnose these cases, it's an emergency, and you must do craniotomy and not aspiration, because as I told you, that the abscess, the pus, will not be very thick, very thin layer surrounding the brain in the subdural space, and opposite to subdural hematoma, we cannot do bowel aspiration because it is useless, number one, and we will not do a clearance or cleaning of the pus from the whole brain. So that we must do a craniotomy. I mean, we are going to open the skin, open big craniotomy flap in the bone, and even open the dura thoroughly, and then you are going to find the thin layer of pus surrounding the brain in subdural space. Then you are going to wash until it's clear, and then it's to be followed by, after closure, I mean, intravenous antibiotics and anticonvulsant. The important complications of subdural empyema are refractory status of epilepticus, and sometimes with the dangerous cortical venous or venous sinus thrombosis. Okay, by this slide, I finished this lecture, inshallah. And next lecture, I will start in fact, after 5 minutes, inshallah. بعد نستراحة إن شاء الله 5 دقائق بس.